I want you to just take a second and imagine a Jenga tower.
Okay, I can picture that.
Right. So you build this really solid interlocking structure. And as long as the pieces are in place, it can withstand a bump to the table.
Yeah, exactly. It's stable.
Right. And in our everyday lives, a functioning health system basically operates on those exact same structural mechanics.
Mm.
Like you get sick, you pull a block, and a local clinic is there.
Hmm.
Or, you need a specialized procedure and another block slides into place with like electricity, sterile equipment, and trained specialists.
Right, it's an entire ecosystem of blocks.
Exactly. But what happens when a crisis hits that table? I mean, a civil war, a sudden pandemic, or just the massive displacement of millions of people.
Everything shakes.
It does. Suddenly the blocks aren't just wobbling. It's like this invisible hand starts systematically yanking them out from the bottom.
Yeah, the foundational stuff.
Right, the water supply block gets pulled, then the safe transport block, the supply chain block. So the fundamental question we are asking today is, when that physical and social architecture starts to collapse, what falls first? And who gets crushed underneath the rubble?
Well, I mean, the Jenga analogy perfectly captures the fragility we are analyzing today because, we instinctively measure the severity of a crisis by looking at the most immediate visible casualties.
Like the numbers on the news.
Exactly. We look at the daily infection rates on a COVID dashboard, or we tally the battle-related deaths in a conflict zone. Those are the pieces visibly crashing to the floor.
Right.
But the structural collapse of the tower itself, it creates this secondary, totally silent wave of casualties.
That's what we don't see.
Right. The breakdown of maternal care, the stopping of routine childhood immunizations, the loss of reproductive autonomy. I mean, these create a ripple effect that alters the biological and social trajectory of a whole population for decades.
And today, we are doing a deep dive into those hidden casualties. We are looking at the people who fall through the cracks when the system fractures, focusing really heavily on maternal, child, and reproductive health.
It's such a critical angle.
It really is. And we have a fascinating stack of sources to guide us through this. We aren't just looking at one event. We are synthesizing information from, a massive 2012 to 2014 global review on reproductive health and emergencies.
Really comprehensive review, yeah.
Yeah. Plus a harrowing 2015 paper on the lasting health effects of the Syrian war on children, and then a 2020 Lancet Global Health correspondence detailing how COVID-19 disrupted maternal care.
Right, bringing in the pandemic side of things.
Exactly. And finally, a highly granular 2020 case study analyzing the impact of conflict in the Balochistan and Fata regions of Pakistan.
And what's fascinating here is that despite the vastly different geographies and timelines.
And total different types of crises, right?
Yeah, I mean, ranging from viral outbreaks to armed insurgencies, the underlying mechanics of the collapse are just nearly identical. The data shows us that the true toll of a crisis isn't isolated to the event itself.
Wow.
Yeah, it embeds itself into the infrastructure, the culture, and even the biology of people who, haven't even been born yet.
Okay, let's unpack this. Because before we can understand those long-term biological effects, we really need to look at the immediate physical collapse.
Right, how the tower actually falls.
Exactly.
Yeah.
How does a health system actually break down in real time? Let's start with the physical toll, pulling from that 2015 data regarding Syria.
Okay.
Because at that time, we were looking at 7.6 million internally displaced people.
Okay.
And another 2.1 million refugees on top of that.
Yeah, I mean, that level of mass displacement, it just systematically dismantles the physical infrastructure of a nation.
It just overwhelms it entirely.
Completely. The World Health Organization reported that nearly 3/4 of hospitals and 1/3 of primary care facilities in Syria simply stopped functioning.
Wait, 3/4?
3/4.
Yeah.
Facilities were destroyed by artillery, or they were abandoned by fleeing medical staff, or, they were co-opted as military bases by various factions.
Which I assume makes them a target.
Exactly. It turns those hospitals into literal targets for opposition attacks. But the collapse of a health system goes far deeper than just losing hospital beds.
Right.
It's the destruction of the foundational public health architecture. So, for example, the Al-Qafsa pumping station in Aleppo was targeted and severely damaged.
When a major water pumping station goes offline, it's not just about people being thirsty.
No, not at all.
The entire sanitation grid fails.
Yeah.
I mean, the sewage is no longer being treated or diverted away from population centers.
And that rolls the clock back a century on public health.
Wow.
Yeah. Without clean water and functioning sanitation, you introduce this immediate skyrocketing prevalence of vectors and waterborne pathogens.
Like cholera.
Exactly. Cholera and typhoid thrive in those exact conditions. And then, you combine that untreated sewage with crowded refugee camps and populations suffering from malnutrition.
Which tanks their immune systems.
Right. Severely depresses their immune response. The epidemiological environment just becomes highly volatile. So diseases that public health officials considered totally managed or even eradicated, they just return.
Like what, specifically?
Well, we saw the reemergence of polio. And right, because traditional conflict metrics often completely fail to capture the operational reality on the ground.
What do you mean by traditional metrics?
So historically, global databases like the Uppsala Conflict Data Program, they measure the severity of a war zone by tracking what they call battle-related deaths, or BRDs.
Okay, so just counting the casualties.
Exactly. A high number of casualties equals a severe conflict zone. But the researchers studying Pakistan recognized that BRDs alone just wouldn't explain why health services were failing in seemingly quiet areas.
So what did they do instead?
They implemented what's called a Delphi methodology.
Okay, so for you listening, the Delphi method, it relies on gathering a panel of deeply embedded experts to build consensus on a really complex problem, right?
That's right.
In this instance, they brought together 39 local stakeholders, like people from government health ministries, UN agencies, NGOs, and local academia.
The people actually doing the work.
Yeah. And they asked these stakeholders to rate various districts as having minimal, moderate, or severe conflict. But they explicitly told them, do not base your ratings on the frequency of gunfights.
Which is key.
They were asked to rate the severity based entirely on how the conflict impacted accessibility to health services for both the medical providers and the civilian community.
And, this methodology yielded a crucial insight. You can have a district that is completely occupied by anti-state elements where the battle-related deaths are practically zero.
Oh, really?
Yeah, because state military forces might not be actively engaging the insurgents in that specific district, so there are no active firefights.
Oh, I see.
By a traditional military metric, that district appears totally peaceful. But because those anti-state elements control the roads and the checkpoints, there is an absolute restriction on movement.
So a supply truck carrying vaccines just cannot enter.
Exactly. Or a woman experiencing a postpartum hemorrhage can't travel to a clinic. By a healthcare metric, that zero-casualty district is a severe conflict zone.
Wow, that completely flips the paradigm of how we define a war zone.
It really does.
I mean, a peaceful-looking town square might actually be under a total medical blockade. And the data from this Delphi consensus totally proved that out.
It did. The numbers are stark.
When researchers analyzed the health indicators in those severe conflict districts in Balochistan, the numbers just plummeted. Coverage for facility-based childbirth deliveries, BCG vaccines for tuberculosis, and exclusive breastfeeding just dropped precipitously.
Compared to the areas rated as having minimal conflict.
Right. So the infrastructure might be physically standing, but the access is paralyzed.
And that paralysis is largely driven by the human element of the collapse. The health workforce in these regions faced conditions that made their jobs practically impossible.
Like what kind of conditions?
We are talking about routine harassment at checkpoints, kidnappings for ransom, and the constant, totally unpredictable threat of landmines on rural roads.
Oh my God.
Yeah. And targeted killings, particularly of polio vaccination workers. Health workers actually had to abandon government-marked vehicles because those vehicles were explicitly targeted by anti-state elements.
So what did they drive?
They tried using their personal vehicles to deliver care, but then those cars were frequently carjacked.
It's the equivalent of trying to put out a massive house fire, but someone is actively shooting at the firefighters holding the hose.
That is exactly what it is.
I mean, even if the clinic has a surplus of medical supplies and the water is running perfectly, the human mechanism required to deliver that care is incapacitated.
Right.
You simply cannot expect a doctor or a midwife to stay in a remote rural clinic if they have no secure housing, no electricity, and are actively getting death threats.
No, of course not. And this environment just triggers a massive brain drain. Senior, highly experienced medical staff systematically migrate to major urban centers where security is tighter.
Which makes sense. You want to protect your family.
Absolutely. But they leave the rural, conflict-heavy areas to rely almost entirely on junior staff or community health workers.
And those workers are incredibly vulnerable.
Extremely. Those community workers are left navigating dangerous terrain with no transportation, minimal supervision, incredibly low pay. The local health system devolves into just a hollow shell.
So the local Jenga tower is swaying dangerously. And naturally, the international community and major global health organizations step in to provide aid.
That's usually the next step, yes.
But the sources highlight a massive systemic flaw in how that global aid is actually structured. Which brings us to the tunnel vision problem.
Right, the debate between vertical and integrated care.
Let's define those terms really quick.
Sure. So in global health, a vertical program is an intervention that takes a massive influx of funding, resources, and specialized personnel, and it concentrates them entirely on eradicating or managing one single disease.
Okay, so it operates in a silo.
Exactly. It is a highly centralized, top-down approach, usually dictated by international priorities. An integrated or horizontal approach, on the other hand, aims to strengthen the entire underlying health system. So improving general clinics, training primary care doctors, upgrading sanitation.
So the system can handle multiple diseases all at once.
Exactly.
And the danger of the vertical approach becomes incredibly clear when you look at the 2020 COVID-19 correspondence from the Lancet Global Health.
Oh, this is such a powerful parallel.
Yeah. During the initial waves of the pandemic, the World Health Organization released interim guidance for maternal care. And the guidelines emphasized, fewer prenatal clinic visits, early discharge from the hospital after giving birth, rigorous screening at facility entrances, and the immediate quarantining of anyone suspected of having the virus.
Right.
And, from a boardroom in Geneva, hyper-focusing on containing a novel respiratory virus makes total logistical sense.
It does on paper.
Yeah.
But dropping those vertical guidelines into the low and middle income countries, or LMICs, which already operate with fragile, under-resourced health systems, it reveals a fatal flaw.
What's the flaw?
Well, the authors of the Lancet correspondence highlight that the primary symptoms of COVID-19, so shortness of breath, elevated heart rate, fever, and fatigue, they almost perfectly mimic the symptoms of severe obstetric emergencies.
Oh, wow. I didn't even think about that.
Yeah.
A woman developing preeclampsia or a systemic infection from a prolonged labor will present with those exact same symptoms.
Precisely. So imagine a pregnant woman arrives at a rural clinic experiencing a life-threatening obstetric complication.
Okay.
Because the clinic is operating under strict, vertically mandated COVID-19 protocols, she is immediately flagged as a suspected viral case.
So she gets pulled out of the maternity ward.
Yes. She's pulled out of the standard maternal care pathway and placed into isolation triage to await a test result.
And in LMIC, testing capacity is notoriously slow.
Very slow. So while she sits in isolation for hours waiting to be cleared of a respiratory virus, the actual immediate obstetric emergency, the preeclampsia or the sepsis, is totally neglected.
That is awful.
Yet the vertical response designed to save lives inadvertently leaves women highly vulnerable to substandard management of childbirth.
And the authors argue that health services in these LMICs are already stripped down to the absolute bare essentials. There is literally no fat to trim.
Right. There's no buffer.
You cannot delay or discontinue essential maternity care to focus on a pandemic without triggering massive, catastrophic secondary mortality.
You just can't.
This vertical approach, shining this massive spotlight on the shiny new crisis while leaving the rest of the room in total darkness, forces the underlying health system to degrade into a really dangerous low normal.
Yeah, that's a great way to phrase it.
And we see the exact mechanics of this vertical trap operating perfectly in the Pakistan case study.
We do. During the conflicts in FATA and Balochistan, the health intervention strategy was incredibly centralized. It was dictated by the capital, Islamabad, and heavily influenced by the priorities of international funding agencies.
So highly top-down.
Extremely top-down. And their response was intensely vertical, focusing overwhelmingly on polio eradication alongside basic emergency obstetric care.
Okay, I have to play devil's advocate here for a second.
Go for it.
Polio is a devastating, paralyzing disease. The global community has been trying to wipe it off the face of the earth for decades. Shouldn't we pour all of our resources, hold constant strategy meetings, and deploy our best personnel to just finally cross the finish line and eradicate it?
I mean, it's a completely valid point, and this raises an important question about resource allocation in fragile states.
Right.
Eradicating polio is an undeniably critical global goal. No one is arguing against that. The issue is the reality of a zero-sum game within a broken system.
The Jenga tower again.
Exactly. When you hyper-focus funding and logistical capacity on one single disease, you inevitably drain those exact same resources from every other medical necessity.
Because there's only so much to go around.
Right, and the Pakistan study documented how this vertical focus actively harmed other sectors. For instance, think about the cold chain.
The cold chain. So that's the network of solar-powered refrigerators required to keep medicines viable in rural clinics that don't have electricity.
Yes, exactly.
Yeah.
If a massive, heavily funded polio campaign mandates that polio vaccines take absolute priority, those vaccines monopolize the limited refrigerator space.
Oh, I see.
So the oxytocin needed to prevent women from bleeding to death after childbirth, or the routine vaccines for diphtheria and tetanus, they are literally left out in the heat.
They just go bad.
Yeah, they're ruined.
The study also noted the human resource drain, right? Like if an international agency is offering a slightly higher daily stipend to workers conducting door-to-door polio vaccinations, the nurses and midwives who staff the general primary care clinics will naturally leave their posts to take the better-paying polio job.
Can you blame them?
Not at all. They have to feed their families. But the result is that routine immunization programs, mental health services, and adolescent care clinics were just hollowed out to feed this vertical polio machine. And the ultimate tragedy here is that despite this massive monopolizing effort, polio eradication in FATA still faced insurmountable hurdles.
It did, because vertical programs frequently fail when they ignore the complex social context of the ground they're operating on.
Right.
In FATA, the international community poured in resources. They even coupled vaccines with food supplies and education to, incentivize the population, yet the virus persisted.
Why, if they had all the funding?
The data points to several contextual failures. There was a highly porous border with Afghanistan that allowed constant viral transmission. There was poor performance and monitoring of the health workers themselves, but most importantly, there was deep-seated community resistance.
The trust issue.
Exactly. Local populations harbored intense mistrust of the vaccination campaigns, which was fueled by geopolitical tensions and misconceptions. Local Pashtun leaders who attempted to advocate for the vaccines were actively targeted and killed by extremists.
Wow. So when you do not have the trust of the community, top-down, non-contextualized global guidelines are completely useless.
Totally useless.
You cannot copy-paste a protocol from a stable, wealthy country, drop it into a conflict-ridden system, and just expect the local population to comply.
You really can't.
If you let one single disease over-influence the care, the entire system debilitates. You end up polishing one block of the Jenga tower obsessively while the entire foundation rots away.
And this tunnel vision is most devastatingly apparent in the realm of reproductive health,
which is often ignored entirely.
Historically, yes, reproductive health has been actively pushed to the sidelines during humanitarian emergencies. Decision-makers frequently categorize it as a secondary concern, or even a luxury.
A luxury during a crisis.
Yeah, they argue it's superseded by the need to treat trauma wounds, manage cholera outbreaks, or secure food supply lines.
Which brings us to the findings of the 2012 to 2014 Global Review on Reproductive Health in Humanitarian Settings.
Right.
And to really understand this data, we need a quick look at the history here. Back in 1994, at the International Conference on Population and Development, the global community acknowledged a stark reality.
That women in war zones don't stop getting pregnant.
Exactly. They do not stop getting pregnant, they do not stop facing sexual violence, and they do not stop needing contraception.
Right.
Consequently, in 1995, a coalition formed the Interagency Working Group on Reproductive Health in Crises, or the IAWG. And their primary achievement was the creation of the MISP.
The MISP, yeah. The Minimum Initial Service Package. It was designed to prevent the exact collapse we are discussing.
What exactly is in it?
It is a set of bare minimum, life-saving reproductive health activities that humanitarian actors are supposed to implement immediately at the onset of an acute emergency.
Okay.
It's important to note it is not comprehensive care. It is triage. It includes protocols and logistical supply kits for preventing and managing the consequences of sexual violence, reducing HIV transmission, preventing excess maternal and newborn morbidity, and, establishing a foundation to build comprehensive services once the acute phase actually stabilizes.
And the global review indicates that the creation of the MISP did move the needle. Between 2002 and 2013, the review found that funding proposals for reproductive health in emergencies increased by an average of 22% per year.
Which sounds great.
It does. Institutional capacity expanded, Awareness of the need grew immensely. But here's where it gets really, well, concerning.
Yeah.
A closer examination of the funding data reveals massive structural blind spots. While agencies were asking for more money, only 43% of those funding requests were actually met by global donors.
Less than half.
Less than half. And more importantly, the distribution of that fulfilled funding exposes severe global biases in what the international community deems acceptable aid.
Right. The biases are staggering.
The review shows a massive surge in funding and programming for HIV-related activities. So HIV prevention became a highly visible, well-funded vertical silo within reproductive health. But other critical areas, specifically family planning and safe abortion care, were critically neglected. And the statistics surrounding the abortion gap are particularly difficult to process.
They really are. The United Nations Population Fund estimates that between 25% and 50% of all maternal deaths in refugee and displaced settings are directly attributable to complications from unsafe abortions.
Right, up to half.
Up to half. Half of all women dying in childbirth or pregnancy-related events in these camps are dying because they lacked access to safe abortion care.
That is an astronomical mortality rate.
It is. And despite that, comprehensive abortion care, which, by the way, includes both the provision of safe abortion and the post-abortion care necessary to treat hemorrhage or infection from a botched procedure, is frequently omitted entirely from humanitarian responses.
But if a specific lack of care is the leading driver of maternal mortality in these settings, how does a gap that lethal actually happen in the field? I mean, why are aid organizations not supplying this care?
Well, the 2014 review highlights that this omission is heavily tied to the policies of funding nations and donor restrictions.
Ah, the politics of funding.
Exactly. Many government donors place strict legal and financial restrictions on their foreign aid, basically prohibiting their funds from being used to provide or even discuss abortion services.
And aid organizations on the ground are legally bound by those strings.
Yes. Furthermore, health providers and NGO managers often operate under profound misconceptions about the national laws of the host countries where the refugee camps are actually located.
Oh, interesting. So they might just assume it's illegal.
Right. They assume abortion is entirely illegal in the host country when, in fact, there might be legal provisions for it, which leads to this terrible chilling effect where providers self-censor their care out of fear of prosecution or defunding.
That's tragic.
And the data totally reflects this void. The global review found literally 0 peer-reviewed papers evaluating comprehensive abortion care programs in humanitarian settings from 2004 to 2013. 0.
0. That speaks volumes. And we see a similar, though maybe less legally complex, gap regarding family planning. The review noted that short-acting contraceptive methods, like daily oral pills or injectable hormones, they were somewhat available in crisis settings.
Right.
But long-acting reversible contraceptives, or LARCs, like IUDs and contraceptive implants, were extremely scarce. And emergency contraception was rarely provided as part of standard family planning kits.
And the absence of long-acting methods is a massive logistical failure that literally costs lives.
How so?
Well, comprehensive family planning services can avert up to 32% of maternal deaths and nearly 10% of childhood deaths.
Just by allowing women to space out their pregnancies.
Exactly. It reduces the biological toll on the mother's body and ensures better nutritional resources for each child. But in a highly transient, completely unpredictable refugee environment, relying on a woman to access a clinic every single month for a pill refill is just completely unrealistic.
Of course. They might be displaced again next week.
Right. But a long-acting implant provides years of protection with a single intervention. Yet the supply chains consistently fail to prioritize them.
But even when the supply chain functions perfectly, and the medical tents are fully stocked with long-acting contraceptives and post-abortion care kits, the sources point to what the review calls the "if you build it, they will come" fallacy. You cannot just erect a clinic with a red cross on it, stock it with commodities, and assume the community will automatically utilize it.
Because the physical presence of a clinic does not negate the sociocultural barriers surrounding reproductive health.
Right. And in the Pakistan case study, we see this vividly. In FATA, even in areas where health facilities were totally operational and staffed, rigid cultural norms dictated that women were strictly prohibited from traveling alone.
Yeah, they couldn't leave their homes without the explicit permission and physical escort of a male relative.
Which means you could have a state-of-the-art maternal clinic right down the road.
Yeah.
But if a woman is culturally or socially bound to her home, that clinic is effectively non-existent to her.
Exactly. And the Pakistan study highlighted how these gender dynamics completely dictate health outcomes across the board.
Yeah, they documented an instance involving a mother who gave birth to boy and girl twins.
I remember this.
And within that specific patriarchal structure, the male child was prioritized for resources. The female infant was neglected. She was breastfed less frequently and not brought in for routine vaccinations.
It's heartbreaking.
It really is. The study also examined adolescent health, noting that in FATA, it was considered actively dishonorable, like a source of deep familial shame for an unmarried adolescent to be seen accessing any form of reproductive health service.
Right, and these social sanctions are not unique to Pakistan. The global review found that across numerous, totally diverse crisis settings, communities frequently shunned highly critical services.
Like what?
Well, like post-rape HIV prophylaxis.
Oh, wow.
Yeah. Humanitarian actors would supply the medication, knowing that if a survivor takes the prophylaxis within 72 hours of an assault, it can effectively prevent HIV transmission.
It's a life-saving window.
But the overwhelming stigma, the profound shame, and just the intense fear of social ostracization or retaliation kept survivors from walking through the clinic doors.
So, supplying the medical commodities is really only a fraction of the battle. You cannot just drop a crate of medicine onto a tarmac and consider the humanitarian mission accomplished.
Not at all. The operational reality is that effective health programming requires intensive, sustained community mobilization.
You have to do the groundwork.
Yeah, humanitarian actors have to engage deeply with the cultural frameworks of the populations they are serving. They must collaborate with local, religious, and community leaders to destigmatize the care and build actual trust.
Because without trust, the supplies mean nothing.
Exactly. The global review documented instances where facility-based childbirth deliveries increased significantly, but only after health actors invested the time to actively reach out, educate, and mobilize the community.
It requires a horizontal approach built on human relationships, not just a vertical supply chain of medical goods.
Right.
Okay, so we have established how the immediate physical infrastructure is destroyed, how top-down vertical aid can inadvertently accelerate the collapse of routine care, and how complex social barriers prevent access even when supplies are present.
It's a lot of breakdown.
It is. But now we have to shift our focus to the aftermath. Because the impacts of these structural failures do not just evaporate when a peace treaty is signed or a virus recedes into the endemic background.
No, they linger.
The trauma and the physiological stress embed themselves into the population, creating these invisible scars. We really need to examine the long-term and intergenerational effects of these crises.
And this is where the true, long-lasting cost of a crisis becomes starkly apparent, especially when we look at the psychological and physiological data in that 2015 paper analyzing the health of Syrian children.
Right.
The trauma experienced by these populations extends far beyond physical blast injuries or malnutrition. A specialized study evaluating Syrian children who had fled across the border to Lebanon as refugees revealed an extraordinarily high psychological burden.
How high are we talking?
76% of the children assessed met the clinical criteria for post-traumatic stress disorder.
76%. That's 3 out of every 4 children.
Yeah. And the paper details the manifestations of this trauma. We're seeing children experiencing chronic nightmares, severe bedwetting, aggressive outbursts, or just the complete silent withdrawal from their surroundings.
And the economic and societal toll of that mass psychological trauma has to be staggering.
Unquantifiable, almost. But within Syria, the educational infrastructure collapsed, leaving half of all school-aged children out of the classroom.
Half.
And among the refugee populations, the situation was even worse. 2/3 of Syrian refugee children were not attending school.
When that educational block is pulled from the Jenga tower, children are forced into adult roles to help their families survive.
They have to. They enter the informal labor market prematurely, facing huge exploitation. And in the most severe environments, they are recruited or coerced into becoming child soldiers.
Which just perpetuates the trauma.
Exactly. The researchers estimated that if those 2.8 million out-of-school children never returned to formal education, the loss of human capital and future earnings will cost Syria up to 5.4% of its entire gross domestic product.
You are literally witnessing the destruction of the economic and intellectual engine of the next generation.
Yeah, but the trauma permeates even deeper than lost GDP or childhood psychology. It actually alters the biology of the population.
This is where it gets really wild.
Right. This is where the science of intergenerational biology completely reframes our understanding of a crisis.
Because we conventionally think of a war or a famine as a discrete event, right? Like a bomb goes off, the damage is done, and then you rebuild.
A start and an end point.
Exactly. But biologically, severe trauma is a slow-motion chain reaction. It is a biological event that passes from a mother directly to her child while that child is still developing in the womb.
And the mechanism driving this is epigenetics.
Right, let's explain that.
So, epigenetics is the study of how environmental factors and severe stress actually change the way our genes are expressed without altering the underlying DNA sequence itself.
So the code stays the same, but how the body reads the code changes.
Perfect way to put it. During a prolonged conflict or displacement, a pregnant woman is subjected to immense chronic trauma. She is facing systemic stress, fear of violence, severe caloric restriction, and, exposure to infectious diseases.
Just constant high alert mode.
Yes. And this profound maternal stress actively alters the physiological development of the fetus. Specifically, it can fundamentally change the child's hypothalamic pituitary adrenal system, commonly known as the HPA axis.
Okay, so the HPA axis is essentially the body's internal thermostat for stress.
Right.
Normally, when you encounter a threat, your HPA axis turns on, flooding your body with cortisol to trigger a fight or flight response. And when the threat passes, the thermostat turns off and your body returns to a resting state.
That's how it's supposed to work.
But maternal trauma essentially rips that thermostat off the wall.
That is a very accurate way to visualize it. Through epigenetic modifications, specifically the methylation of glucocorticoid receptor genes, the unborn child's HPA axis is permanently recalibrated.
Wow.
The child is biologically programmed in utero to operate in a high-threat environment. Their baseline stress response is set permanently to high alert.
So they are constantly bracing for impact biologically.
Exactly. Consequently, they are born with a heightened lifelong susceptibility to severe mental illness, anxiety disorders, and a physiologically impaired ability to regulate stress.
I mean, the war is literally rewriting the stress response mechanisms of people who haven't even taken their first breath yet.
It is. And we have concrete historical precedents that completely validate these epigenetic mechanisms.
Right, from older conflicts.
Yeah, the 2015 paper on Syria draws direct parallels to exhaustive studies conducted on the survivors of the Dutch hunger winter during World War II and the Biafran conflict in Nigeria in the late 1960s.
What did those studies show?
Those long-term studies definitively proved that when a mother experiences severe famine during pregnancy, the fetus permanently alters its metabolic programming to survive in a low-calorie environment.
And adapts to starving.
Exactly. But decades later, when those children grew into adults and finally had access to normal food supplies, that altered metabolism caused massive spikes in chronic diseases, like diabetes, severe hypertension, and cardiovascular disease.
So the war starved the mother, and 50 years later, it caused your child's heart to fail.
Yes. The legacy of the war is embedded in their tissue.
And we can observe the very beginnings of this trauma-altering biology right now in the Syrian data. There is a specific metric in the paper that just perfectly illustrates how psychological terror dictates medical outcomes.
Ah, the C-section data.
Yes, the fear metric. Among Syrian refugee women living in Lebanon, the rate of cesarean sections skyrocketed to incredibly anomalous levels. Before the conflict, the baseline C-section rate in both Syria and Lebanon was approximately 15%.
Which it's pretty standard.
Right. However, among the refugee populations, it jumped to 35%. And in one specific clinical study of 452 pregnant refugees, the C-section rate was 45%.
I mean, a C-section rate of 45% in a displaced population is not driven by sudden, widespread anatomical changes or a sudden spike in medical necessity.
No.
It is a direct response to environmental terror.
Because you have to ask, why would a woman who has just fled a war zone, who is living in a highly precarious refugee settlement, voluntarily elect to undergo major abdominal surgery if she doesn't medically have to?
She chooses surgery because the alternative is unimaginable unpredictability.
Right.
These women were existing in deeply insecure environments. The prospect of going into spontaneous natural labor in the middle of the night is terrifying when you do not know if a doctor will be available, or if a military checkpoint will allow you to pass, or if violence will literally erupt on the road to the clinic.
The environment is entirely out of their control.
Entirely. Therefore, they opt to schedule a C-section. They are making a calculated decision to sacrifice their long-term physical health to gain just a tiny sliver of logistical control over exactly when and where they deliver their child.
But a C-section is major surgery.
It is.
In a low-resource refugee setting, it carries massive risks of severe infection, hemorrhage, and long-term maternal morbidity.
Right. But the trauma of the war zone forces them to choose a dangerous surgical intervention simply to avoid the sheer unpredictability of their environment.
It's just devastating. And I mean, the picture we have painted throughout this deep dive is incredibly grim.
It's heavy.
We have health systems collapsing from artillery fire and viral surges.
Yeah.
We have well-meaning global organizations blindly focusing on single diseases, which inadvertently drains the resources needed to keep mothers and children alive. We have rigid cultural barriers locking women out of life-saving care. And we have the sheer terror of war, epigenetically altering the biology of the next generation.
The Jenga tower has completely fallen.
Right, so the ultimate question we have to ask the sources is, how do the experts suggest we fix this? If the Jenga tower is destined to be hit, how do we build a structure that bends but doesn't break in the chaos?
The foundational answer lies in moving away from these simplistic top-down models and embracing the inherent complexity of local systems.
What does that look like in practice?
Well, the Global Review cites the philosophy of the late Nobel Prize-winning economist Elinor Ostrom. She argued that the ideal international aid system should not operate as a series of prefabricated one-size-fits-all solutions deployed from Western capitals.
So no more copy-pasting.
Exactly. Instead, aid should foster adaptive, dynamic systems that integrate with the complexity of the real world. The ultimate goal of any humanitarian intervention should be to leave the developing country more autonomous, less dependent on foreign aid, and vastly more capable of crafting its own resilient future.
In practical terms, that means we have to stop trying to force a sterile, highly rigid health protocol designed in a Geneva boardroom onto a mountain village in Balochistan.
Right. The humanitarian sector has to listen to and integrate with the local operators.
And our sources offer very specific, grounded solutions for how to execute this shift.
They do. The first, and perhaps most critical solution, is pre-crisis preparedness.
Because you can't wait until the bombs fall.
Right. You cannot wait until the pumping stations are bombed or the virus is aggressively spreading to begin building a robust health system. The Global Review emphasizes that emergency humanitarian response must be inextricably linked with long-term international development.
To funding before the disaster.
Yes. Global donors and aid agencies need to invest heavily in funding national medical schools, actively supporting local ministries of health, and building deep community trust long before a disaster strikes. You have to build the structural resilience into the system during peacetime so the tower can withstand the shock.
And when a crisis inevitably does hit, the system has to be wildly adaptable, particularly regarding the workforce.
Oh, definitely.
I want to highlight a really brilliant logistical solution from the Pakistan study regarding the Quiche district in Balochistan.
A rotation model, yes.
Yeah. They faced a universal problem in conflict zones. Senior, highly trained doctors absolutely refused to move permanently to dangerous, remote rural areas.
Which is a completely rational response.
Totally. And the traditional response from aid groups would be to either force them, which leads to resignations, or give up and leave the rural clinic unstaffed.
Right.
Instead, they implemented an adaptive task-sharing and rotation model. They allowed the senior specialists to remain based in the safer, more secure district center, but mandated that they travel out to the remote, high-conflict clinics on a rotating schedule, like 1 week out of the month.
And this specific logistical adaptation provided the rural populations with consistent access to high-level specialized care without requiring a doctor to permanently relocate their family to a war zone.
So smart.
It is. That rotation model is a perfect real-world application of Ostrom's adaptive systems. But you also have to address the fundamental baseline needs of the workforce on the ground.
Right. The humanitarian sector cannot just demand endless heroism from local staff.
No, you can't run a health system on martyrdom. The Pakistan study explicitly noted that if you want a doctor, a nurse, or a midwife to stay at their post in a rural clinic, the government and the aid agencies must provide secure housing.
The basics.
Yes. They must ensure the facility has reliable electricity and clean running water. And crucially, they must coordinate security so the staff aren't living in constant fear of being kidnapped or killed.
If you do not secure the physical and psychological safety of the workforce, the entire mechanism of care delivery just collapses.
Completely. And finally, the sources demand a shift toward absolute integration.
Right, tying back to the COVID-19 paper.
Exactly. The Lancet correspondence on COVID-19 makes a powerful, urgent plea regarding how we handle funding during an acute emergency. They argue that we must abandon the vertical, single-disease silos.
Even for pandemics.
Especially for pandemics. When the international community pours billions of dollars into a crisis response, that funding must be integrated into fortifying essential, everyday care.
So instead of exclusively buying diagnostic tests for one specific virus, aid agencies should use that influx of pandemic funding to permanently upgrade the water, sanitation, and hygiene infrastructure in maternal health wards.
Exactly. We have to use the massive momentum and funding of a crisis to establish a robust new normal of improved primary care, one that will continue saving lives long after the specific emergency has faded from the headlines.
It is about recognizing that every single piece of the tower is connected. You cannot reinforce one single block at the very top while allowing the foundational blocks at the bottom to crumble.
No, it just doesn't work.
So let's pull all of these threads together. We have explored how crises systematically shatter the physical infrastructure of a country, eliminating the baseline requirements of water, sanitation, and safe transport. We have seen how tunnel vision aid, despite its absolutely best intentions, can actively drain resources and neglect critical everyday health needs, especially comprehensive reproductive health and safe abortion care.
Mm-hmm.
And we've examined the harrowing biological reality that the terror of war actively alters the physiological stress responses of unborn children. So what does this all mean for you listening?
Well, it means we must fundamentally change how we view healthcare in fragile settings. Health is never simply a matter of biology or medicine.
It is inextricably linked with sociology, with political science, and with highly complex logistics.
Always.
A $1 million supply drop of the world's most advanced vaccines is utterly useless if the community does not trust the people administering them, or if the roads are too dangerous for a mother to walk down.
And that interconnected reality leaves us with a really profound concept to consider.
What's that?
Well, we have spent this entire discussion analyzing acute, highly visible crises, armed insurgencies in Pakistan, the devastating civil war in Syria, and a sudden global pandemic.
Things that make the front page.
Right. But the mechanisms of collapse and biological trauma we've detailed are not confined to active war zones.
Wow.
If chronic stress, severe nutritional deficits, and systemic infrastructural neglect can epigenetically alter the next generation in a refugee camp, we are forced to turn that lens onto our own societies.
You're suggesting that these exact same mechanisms are operating in places that aren't on the international news every night.
Exactly. I want to ask, what invisible, slow-burn crises in your own seemingly stable community, whether it is systemic generational poverty, environmental pollution in marginalized neighborhoods, or vast healthcare deserts where maternal care is inaccessible, are currently acting as a slow-motion conflict zone?
That is a chilling thought.
What daily unrecorded traumas are right now shaping the biology, the stress responses, and the mental health of tomorrow's children in your own city?
That is a heavy, incredibly necessary question to sit with. Because the Jenga tower of our own society might look perfectly stable from a distance, but if the foundational blocks at the very bottom are slowly crumbling under the weight of systemic neglect, we are all eventually going to feel the fall.
We absolutely will.
Thank you for joining us on this deep dive into the hidden casualties of global crises. Keep looking beyond the immediate headlines, keep asking the difficult questions about how our systems operate, and we will see you next time.